Okay, hey guys. So today we're going to be explaining the shoulder region, and then we'll go into the shoulder joint and the other joint around this region. So let's get started. First of all, we need to understand the concept of the pectoral girdle. Now, the pectoral girdle is basically the two bones, which are the clavicle and the scapula, that are going to be connecting the upper limb with the main body. Now, this is going to create three joints, which is the shoulder joint, known as the glenohumeral joint, because of the glenoid fossa created by the scapula and the humerus. There's a acromioclavicular joint between the acromion process and the clavicle, and we're going to have the sternoclavicular joint between the sternum and the clavicle. Some important bony landmarks that you should know are the clavicle and the scapula, acromion process of the scapula, which is going to be superiorly extending out here, and then the coracoid process of the scapula, which is this one. And if you can see it in surface anatomy picture right here, this is going to be the acromion process, and this is going to be the coracoid process. Now, what is important to know these points? Because basically when I'm going to start describing the muscles for you, knowing where they are exactly attaching is going to help you basically like understand the function rather than just memorizing them. So you want to know where each point or each muscle is attaching so that it will help you throughout the process, okay? So again, this is the clavicle, this is the acromion process, and this is the coracoid process, and this is going to be the humerus. Now let's start by describing the bony landmarks. We're going to start by talking about the clavicle, then the scapula, and then a little into the humerus. So first of all, the clavicle, what you should know
Excuse me, can you raise your voice, please? Can you raise your voice?
Okay, one second. I think I need to change the mic because I can't open the Zoom settings too. All right, can you stop the recording for a second? Now, some bony landmarks on the clavicle are the conoid, tubercle, and the trapezoid line. Now, you guys don't need to focus much on the bony landmarks on the bones, but like it's good to know them, okay? Now, the conoid, tubercle, and the trapezoid line are important because they're offering attachments for the coracoclavicular ligament that we'll discuss later on. And another thing that you should know is that the costoclavicular ligament is going to attach at the sternal end of the clavicle. Now, this is going to be discussed in the lab section. They're basically going to tell you about how the acromial end is going to be flat and the sternal end is going to be round. Now, to be honest, for us, when we first looked at it, it was a little bit confusing. So I got you guys this picture to help you understand how exactly it's going to be. Now, this is going to be discussed, or like you're going to understand it if you look at it in a third person point of view. This is going to be the sternal end because it's connecting to the sternum. As you can see, it's rounded over from this side, while the acromial end is going to be flat. So if you look at it in a 2D view, you won't really get it unless you go into a third person point of view. So this region is going to be the flat region. Now, other important points is basically that the sternal end is going to be attached to the sternum. The acromial end is going to attach to the acromion process. And we'll get into the ligaments later on. Now, this slide was included in Dr. Atif's lecture. And I just want to point out the Fuchs injury. And the Fuchs injury, Dr. Atif loves it so much. It's basically a fall on outstretched hand. And I even remember he even got us a question that was like, what are the injuries that you might get in a Fuchs? It's basically a Fuchs is going to damage the shoulder, it's going to damage the humerus, it's going to damage the arm, it's going to damage the hand, it's going to damage everything. So just be aware of it. And Dr. Atif is going to bring it up so much in the MSK. All right. Now, this is another X-ray landmarks for you to see. Now, this is a fracture, okay? Now, for the clavicle, what you should know is that the clavicle is mostly fractured at the midpoint between the medial 2/3 and the distal 1/3, right? So at this region. So whenever it's mentioned that there is an injury on a clavicle, you just want to think for your level, you just want to think about a fracture between the medial 2/3 and the distal 1/3, which is the most common fracture subside for the clavicle, right? Now, what happens in a clavicle fracture, as you can see right here, is that the proximal 2/3 part is lifted up and the distal 1/3 part is going down. Why this happens is because of the sternocleidomastoid muscle. The sternocleidomastoid muscle is going to be attaching over from the neck part to the clavicle. And it's once it fractures, it's going to contract and pull this proximal part upward. And the distal part is going to go downward. And this is a really important concept that you guys might get questioned about, okay? If you were asked what muscle is responsible for this dislocation, or like why the proximal part is lifted up, it's the sternocleidomastoid muscle. Okay, keep that in mind. Now, the next point is going to be the scapula. Now, what you should know about the scapula, the main points, is the spine of the scapula, which is going to be on the posterior aspect. The spine is dividing the scapula posteriorly into the supraspinous fossa and the infraspinous fossa, which are important for the attachment of the supraspinatus muscle and the infraspinatus muscle. while anteriorly, you're gonna have the subscapular fossa for attachment of the subscapular muscle. So guys, like the muscle names are pretty similar to like the location name. That will help you make you understand it and like memorize where it is. Okay, so we've got the supraspinous and the infraspinous, supraspinatus and infraspinatus muscles, and the subscapularis muscle. Another 2 points that you should know are the coracoid process and the acromion process. As we mentioned them earlier, the acromion will be like more superiorly, and the coracoid is going to be more anteriorly. And there are some borders that you could look at them, like medial border and lateral border. Don't really focus much on them. I mean, you can just understand them. Superior is the upper part, medial border is the middle, and the lateral is on the lateral side. Now, what happens is that in the lateral view of the scapula, you can see this basically a small hole called the glenoid fossa. Now, the glenoid fossa is the point where the shoulder joint is going to attach the humerus, and hence we get the name the glenohumeral joint. And underneath is going to be this infraglenoid tubercle, which is also good to know. Okay, the last part is going to be the humerus. Now, the humerus, what you need to know about the humerus is that there is the greater tubercle, which is going to be laterally, and there is the lesser tubercle, which is going to be more medially and anteriorly. Between them, you're going to have the intertubercular sulcus, and then there's anatomical neck and the surgical neck. What is the significance of the surgical neck? And this is a really important concept right here, is that the shoulder fractures or the humerus fractures, the most common site is going to be at the surgical neck. And this fracture might lead to other injuries that we'll discuss later on. So the most common site is the surgical neck. And another site of fracture that you might get, but is not as common, is the mid-shaft fracture, which also damages other structure that we'll discuss. Now, the greater tubercle and the lesser tubercle and the intertubercular sulcus are important bony attachment sites for muscles. And one of the muscles that's going to be passing through the intertubercular groove is the tendon of the biceps long head. And so the tendon of the biceps long head, because it travels through these two bony regions, it could get inflamed, and it's one of the most commonly inflamed tendons. Now, as we said, the supraspinatus, infraspinatus, and teres minor are really important for muscle attachments. Now, what this picture right here shows you, it shows the sits muscle or the rotator cuff muscles. So later on, we'll discuss the rotator cuff muscles. They're basically going to be attached in this type of form, where you're going to have the supraspinatus passed posteriorly, the infraspinatus, the teres minor. All of these guys are going on the lateral side, which is where the greater tubercle will be sitting. And then you got the subscapularis more anteriorly on the lesser tubercle. We'll get into those later when we're talking about the rotator cuff, but just keep that in mind, this picture, whenever you're trying to name or like whenever you're thinking about where these rotator cuff muscles are attaching. Okay, so let's start talking about the muscles. First of all, we're talking about the shoulder region muscles. Now we start by discussing the posterior muscles. Now the first and most important muscle is going to be the trapezius muscle. The trapezius muscle is basically extending over from the neck all the way down to the last thoracic vertebra. It's divided into 3 fibers, the superior, the middle, and the inferior fibers. Okay, so guys, I'm going to give you a way so that you really know how the muscles are functioning instead of just purely memorizing it. So what you need to do is basically try to imagine where the muscle is coming from and where is it ending. So these three muscle fibers of the trapezius muscle are going to be attaching at the acromion, the scapular, the clavicle part, basically over at this region. And so if we take on the first fibers, which are the superior fibers, so the superior fibers are going from the top of the neck and extending down to this part. So whenever you're contracting them, you're basically trying to small these muscles. So what's going to happen is that we're contracting it. What happened to my arm? My arm is basically, or the scapula, since they're attaching at the scapula is elevated and it's laterally rotated. Now, lateral rotation and medial rotation of the scapula are basically, like, in order to know them, they're different from the humerus lateral rotation. The humerus, the shoulder joint, lateral and medial rotation are basically by moving the hand that way. But scapular lateral and medial rotation, just focus on this inferior part, okay? So if this inferior part is going outward, it is a lateral rotation. If it's going inward, it's a medial rotation. So let's look at the superior fibers again. They're attached over at the scapula and we're contracting them. So what happened is that the scapula got elevated and the lower part got pushed outward. So it's laterally rotated, all right? And let's look at
repeat, please?
Okay, so in order to know how the muscle, is the angle, can you guys see, like, whenever I'm trying to present it for you, can you see my camera?
You can see it better now.
Yeah.
Okay, so basically, in order to know how the muscles are really functioning, try to imagine where the fibers are coming from and where they're ending. And then try to shrink them or like contract it and see what happens in your body, okay? So let's think, for example, the superior fibers of the trapezius muscle. They're extending up from the top part of the head and they're going down to the back of the scapula, right? So what happens is when I'm contracting it, I'm basically pulling my hand that way because that's what happens when the muscle is contracting. At this, since it's attached to the scapula, what happened is my scapula got elevated, right? Which is the first function of the superior fibers. And then the lateral rotation part, did you guys get it? That the lateral rotation part, you look at the lower part of the scapula. So once it's elevated, the scapular lower part is pushed outward. So it's laterally rotated. Now for the middle fibers, it's gonna be from the middle. It's gonna come around here. So what happens when I'm pulling it back, I'm retracting my scapula. Basically, like instead of the scapula being that way, it's gonna be that way because it's getting pulled from this side, right? For the inferior fibers, which are gonna come in from below, they're gonna hold the scapula and they're gonna pull it downward and inward, right? So they're pulling it down and they're pulling it medially. You guys get this point? Because I'm gonna use it for all the muscles. It's basically how I want you guys to remember the muscle functions. Was it clear?
Yes, but can you talk a little slower?
Okay, sorry.
Thank you.
Now, what you need to know about the trapezius muscle is basically it's the muscle that's responsible for the shrugging motion, and it is supplied by the cranial nerve 11. XI is 9, right? No, XI is 11. Okay, the cranial nerve 11. So why this is important is basically if you get any question about how you want to check for the shrugging motion or any question about the cranial nerve 11 damage, you immediately like want to correlate shrugging, trapezius, and cranial nerve 11 together, or the spinal accessory nerve. You might get both names. And the other muscle, which is basically a small muscle, which is the levator scapulae muscle. It's not really as important muscle, but basically do the same thing in order to imagine the function. It's attaching from the cranial vertebra over at the superior border of superior angle of the scapula. So if a muscle is attaching here and I'm contracting it, what happened is my scapula got elevated. Okay. And so it's supplied by the nerve C3, 4, and 5. Now the nerve supplies, I won't go over them because you guys have them written here, but they're really important. Okay. You should know every nerve supply for the muscles. Okay. Now this is another summary for the nerve supplies and some functions. Now the next muscles, now what we're gonna do, we're gonna add this thoracolumbar fascia, which is basically just like connective tissue fascia. It's not really important. What we get is the latissimus dorsi muscle. Now the latissimus dorsi muscle is the major muscle that's going to be attaching from the thoracolumbar fascia all the way anteriorly to the humerus. And you should point out, so in order to understand the function of the latissimus dorsi, is going back from my back, and it's gonna come anteriorly, then it attaches here into the intertubercular sulcus of the humerus. Did you guys see that? So it's coming from the back and it's gonna come anteriorly to the intertubercular sulcus. So whenever I'm contracting it now, what's gonna happen? I'm gonna have my shoulder joint is gonna get pushed right that way. So that's a medial rotation. And since it's from the back, it's gonna pull it back. So that's an extension. And since it's coming from the side or from the middle of my body, going outward, when it's contracting it, it's gonna pull it closer to my body. So what happened is we just extended, adducted, and medially rotated the shoulder joint. Was that clear? And so another name for the latissimus dorsi muscle is the swimmer's muscle because of the motion that it allows. And the nerve supply for the latissimus dorsi muscle is the following nerves: C6, 7, and 8 for the thoracodorsal nerve. Another two small muscles are the rhomboid major and minor. They're not really as important as well, but like you should know them. Basically supplied by the dorsal scapular nerve. And they're doing the same thing there since they're coming from the medial side, attaching to the medial border of the scapula. Once they pull the scapula, they're going to pull the scapula backward, which is basically retracting the scapula. And since they're retracting the scapula from both sides, it's going to give you the squaring of the shoulder shape. Now, one important concept right here is the clinical concept, is that this triangle is going to be created between the trapezius muscle and the latissimus dorsi muscle. Now, since this triangle has no bone, no muscles over it, or no any bony projections as much over it, it's going to be allowing the doctors to auscultate this region or to listen to your breathing sounds. And it's known as the triangle of auscultation. Okay, so this is the triangle of auscultation. Now, this is again the summary for the latissimus dorsi muscle. As you see, it's coming from the posterior side, and then it goes over and attaches anteriorly. And that's why we get these type of motions. Now, the next two muscles, okay, the levator scapula and the rhomboid major minor, this is another summary. Now let's go anteriorly. So anteriorly we have from superficial angle, we have the pectoralis major muscle, which is basically the large chest muscle. And then under it, we're gonna have two muscles, the pectoralis minor and the serratus anterior muscle. So let's start talking about the pectoralis minor and the serratus anterior muscle, because these two muscles have an important clinical significance. And there we go. Okay, I'm going to start with the pectoralis major. Now, pectoralis major is not really that important. I mean, it is important, but like not the clinical importance. Basically, pectoralis major is divided into two parts. The superior part, which is attaching from the clavicle. Therefore, we're going to call it the clavicular head. And the other part attaching at the sternum and the costal. Anything that refers to costal is basically talking about the costal cartilages on the ribs. Or you can just like think about it. Anything costal is ribs. So a sternocostal head is going to be attached on the sternum and the costal part, going over to the humerus. And the clavicular head is going to come from the clavicle all the way into the humerus, into the intertubercular sulcus of the humerus. Okay, so the function of the pectoralis major, since it's a muscle that's coming out from this side, and it's going to attach on the lateral lip of the intertubercular sulcus. Now, later on, we're going to take two other muscles that are going to be attaching on the intertubercular sulcus. I'm just going to explain them now, and then I'm going to mention them later. So first of all, in the intertubercular sulcus, we're going to have a lateral lip, which is basically created with the greater tubercle, and the medial lip, which is created with the lesser tubercle, and then the floor of the intertubercular sulcus. Now, the three muscles are going to be the latissimus dorsi, which we just explained. It's going to come from the back, and then it's attaching on the floor of the intertubercular sulcus. The next muscle is the pectoralis major. The pectoralis major is going to come from anteriorly, go all the way over, and attach at the lateral lip. And the last muscle is going to be muscle coming from the posterior side, which is the teres major muscle. The teres major muscle is going to come from posteriorly and attach at the medial part or the medial lip of the intertubercular sulcus. Okay, so we got three muscles. On the floor, we got the latissimus dorsi. On the lateral side, we got the pectoralis major. And on the medial side, we got the teres major, the major muscles. Okay, so let's talk about the function of the pectoralis major. So since it's a muscle that's going to be attached anteriorly over at the lateral lip, once we contract it, what's going to happen? We're going to see medial rotation. We're going to see flexion. Since it's anteriorly, flexion of the arm is basically moving it forward. Extension is moving it backward. So we're going to see flexion, which is basically it's going to be moved forward. We're going to see it medially rotated and adducted or brought closer to the body. Now, the pectoralis major is one of the most major or most important muscle when it comes to medial rotation. Okay, so it's like the major muscle for medial rotation is the pectoralis major. Okay, so the nerve supply for the pectoralis major is the medial and the lateral pectoral nerve, C5 to T1. You guys should learn these in the brachial plexus lecture. All right. Now let's go to the pectoralis minor and the serratus anterior muscle, because these.
Excuse me?
Yes.
Can you slow down a little bit?
Oh, I'm sorry.
Thank you.
Okay.
We're kind of struggling to understand you because like you're going really fast.
Okay. Do you guys need me to explain anything? I'll try to go slower. Like, did you get the previous parts?
There are some questions.
Okay, what are the questions? I'm gonna go over them, then I'm gonna go over this part.
Someone asked you to go over the latissimus dorsi. You were explaining the attachment and how it moves.
Okay. I'm going to use this picture here so you can see it. So the latissimus dorsi muscle is coming from the back side and it's going to attach over anteriorly, as we just said, into the intertubercular sulcus, the floor of the intertubercular sulcus right here. So this is the greater tubercle, this is the lesser tubercle, and this is the floor of the intertubercular sulcus. Since it's a muscle that's going posteriorly and then it's going to attach anteriorly, what happens is like you try yourself. You try to put your arm like that, like mimic the motion of the weight of the muscle, and then contract it. And like, you know, you pull it alone. Then what happened is that my arm got medially rotated, which is basically this is medial rotation and this is lateral rotation. Since it's from the back and it pulled it from the back, it's gonna extend my arm. So that's, or moving it backward, that's extension. And since the muscle is originating medially and it's going laterally, when it pulls the lateral part inward, it's gonna be adducting the muscle. Okay, so we adducted the muscle, we medially rotated it, and we pulled it backward, extending the muscle. You get it?
Yes. Any other questions? There's one that asked about whether we have to memorize the C numbers for the nerve supply, like C5, C6.
You're gonna have to memorize them for the brachial plexus. So I guess yes.
طيب, how can we get the questions on it?
Questions might come as like, what nerve supplies, for example, this muscle, then you could get like the name of the nerve, or you could get like the cranial parts, like C6, 7, 8. I think it was mostly brachial plexus part though. Like he could tell you, for example, a C8 and T1, and then like what muscle that creates, what nerve that creates. Did you guys take the brachial plexus lecture?
Yes.
Yeah, I'll meet with the pal tutor, or not yet.
I think it's tomorrow.
Okay, he's gonna explain them to you guys. Because the brachial plexus basically goes over all these muscles and their or these innervations, I mean. Okay, any other questions? I'm gonna try to go slower. I'm sorry, guys. Anything else? Should I keep on?
Yeah, thank you. You can keep going.
Okay. So the next point, which is an important point, the pectoralis minor and the serratus anterior muscle. So I'm going to go over the nerve supply first of all. The pectoralis minor is supplied by the medial and lateral pectoral nerves, which are the same innervations for the pectoralis major. And the serratus anterior is supplied by the long thoracic nerve, C5, 6, 7. Okay, so focus mostly on the long thoracic nerve, C5, 6, 7, supplying the serratus anterior muscle. Now, why is that? Basically, okay, let's start first of all describing the function of the muscles. The pectoralis minor is going to attach over from the ribs, third to fifth, second to fourth, and it's going to go over attaching on the coracoid process on the scapula. Okay, so let's consider this the scapula, and this is the muscle that's attaching over at the coracoid process and the scapula. And then we contracted the muscle, we pulled it inward. So the scapula, what happened to the scapula is that it got laterally rotated on this side, and then it got pulled in forward. Okay, now this is basically the protraction motion of the scapula. Since we're protracting it or bringing it forward. What happens also is we got the serratus anterior muscle, which is going to be coming from the rib cages, and it's going to go posteriorly to attach at the medial border of the scapula. Like over here, it does not attach at the middle of the scapula. It goes all the way to the back. It goes all the way to the back and attach at the medial border, like the back border of the scapula. So since the pectoralis minor just did the contraction and created this motion, the serratus anterior is going to attach over at this part, and it's going to contract to pull it in to fix the shape. You get it? So again, let's go over it again. The pectoralis minor attached. So this is the scapula. It's normally the pectoralis minor attached at this part and pulled it in like that. Now the serratus anterior comes over, attaches at this back part, at the medial part, and pulls it in to fix the shape of it. This allows for the protraction of the scapula and moving it forward without creating any morphological deformations. However, any damage to the long thoracic nerve, which is supplying the serratus anterior muscle, is going to give you this presentation, known as the winging of the scapula. Why this happened is basically the pectoralis minor pulled the scapula inward at this angle, but there was no serratus anterior supply to fix the angle. Therefore, you got this basically deformation right here. The scapula got pulled in forward, and this protrusion appeared backward that wasn't fixed because this is the back side. This protrusion wasn't fixed by the serratus anterior. Okay, so anything that you get in relation to the winging of the scapula, immediately think of the long thoracic nerve damage injury or the serratus anterior muscle. C5, 6, 7. Now, this serratus anterior muscle is also known as the boxer's muscle, which is basically because of the action or protruding, because it protrudes the scapula forward. Okay, did you guys get the winging of the scapula part? Because it's really important and you're most likely getting a question about it.
Yes, we got it.
Okay, so this is again summary for the muscles. And okay, let's talk about the intrinsic muscles now. So the first muscle we're going to have is basically from the superior fossa of the scapula, the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. These four muscles, just memorize them that way. Like memorize them as your name. SITS muscle, the sits muscle. Supraspinatus, infraspinatus, teres minor, subscapularis. Whenever anyone mentions one of the muscles, like just list the four muscles together. Supraspinatus, infraspinatus, teres minor, and the subscapularis. These muscles are referred to as sits muscle or the rotator cuff muscles. They are going to provide stabilization for the shoulder. Now, this is the nerve supply for the suprascapular, for the supra and infraspinatus, the teres minor and subscapularis. Now, an important function is the supraspinatus function. It's initiation, it's providing the initiation for abduction, right? Why is it basically like one of the one I focused on most out of these four muscles? because the infraspinatus, teres minor, and subscapularis, like you guys should know the functions, but like they're supplied by like these functions are carried out by other muscles. So like questions like, you should know these muscles, but like it's most likely if you get questions, it's going to be talking about like other major muscles. Like lateral rotation might be talking about the muscles in the back, such as the trapezius. Okay, now the supraspinatus is initiating the abduction. And an important point you should know is basically that the supraspinatus tendon is most prone to inflammation. Anything that ends with itis, tendinitis, is basically referring to inflammation. So if I say supraspinatus tendinitis, it is inflammation of the supraspinatus muscle tendon. And why is that? Because as you can see, this is the scapula and the acromion process on the backside. They're going to be connecting over, and they're creating this tunnel underneath them, subacromial tunnel, it's referred to as that, and basically between these two bony connections and the humerus joint. Now, this is basically causing the supraspinatus muscle to get inflamed in case of any like friction that's occurring with the muscle. So the supraspinatus tendon is one of the most inflamed tendons in the shoulder region. Okay. Another thing that you're going to have passing through this tunnel is the subacromial bursa or the subdeltoid bursa. It's basically the same thing, but it's under here, under the acromial process, and then under the deltoid muscle, so it's referred to as the subdeltoid bursa. It undergoes the same issue, which is basically the bursitis, inflammation of the bursa, subacromial bursitis. It happens due to, for example, hypertrophy of the supraspinatus muscle, which will push the subacromial bursa over at the bony region and will cause the friction, which will cause the inflammation. Now, the supraspinatus tendinitis and the subacromial bursitis together create something referred to as the painful arc syndrome. The painful arc syndrome is basically when you can't abduct your arm between 40 and 120 degrees. It's going to cause excruciating pain. And this is because of the inflammation at this region, all right? So this is the supraspinatus region, and this is the muscle coming out here. If I'm abducting my arm, moving it upward, I'm compressing this part, I'm compressing the tunnel, which will cause a lot of pain. And it's referred to as the painful arc syndrome. Now, bursitis, which is inflammation.
I have a small question. What's a bursa?
A bursa, okay, yes, good question. So a bursa is basically just a sac filled with fluid in order to allow for lubrication between these muscles. It's just a fluid-filled sac that's allowing for lubrication between these muscles. There's also the subscapularis bursa, but it's not as important. There's not really any much clinical significance for it, as much as for the subacromial bursa. Okay?
Which allows what?
Allows for lubrication, like it limits the friction between these two bones.
Oh, so like it doesn't, make friction. It's like the synovial fluids?
Yeah, it's basically filled with fluid to do that.
Okay. Same function.
Yes. Okay. So the painful arc syndrome, angles between 40 and 120 degree abduction will cause a lot of pain because of inflammation to the supraspinatus tendon and the subacromial bursa. It's also referred to as the impingement syndrome, which is basically the same thing. Okay. Now, this concept is also another very, very important concept, the quadrangular spaces and the triangular spaces. I'm going to go over to this slide that I brought for you guys. They're going to mention it for you in the lab. I don't know if they mentioned it already or not, but basically what you should know is that the three spaces that are going to be created are one quadrangular space, which is basically 4 angles, and then 2 triangular spaces. They're going to be created between the humerus, which is the hand bone, and the triceps long head tendon. The 2 other muscles that are going to create that are the teres minor and the teres major muscles. Now, let's first of all analyze. Okay, I'm going to go over the function of the teres major, then I'm going to go over them again. So the teres major is supplied by the lower subscapular nerve, and it's basically going to attach over. Where did we say the teres major is attaching? It's coming from the back, and it's attaching at the intertubercular sulcus, the medial lip. Okay. The pectoralis major was at the lateral lip. The latissimus dorsi was at the floor, and the teres major, it's a major. So like consider it, count it with the pectoralis major muscle. It's attaching at the medial lip. All right. So we got the humerus and the triceps long head. Okay. Now we have the teres minor muscle and the teres major. So let's consider this the scapula right here. The humerus on this side, and this is the triceps tendon. The triceps tendon is attaching over at this part at the scapula. Now, if you go a little down, like at this part, there's gonna be the teres minor coming out first, and then the teres major coming out first. Okay, so we got the teres minor and the teres major. Now, the teres major, as we said, associated always with the pectoralis major and the latissimus dorsi muscles. Let's consider it the pectoralis major muscle because the major and major. Okay, so the pectoralis major muscle is the one that's found anteriorly, right? So the teres major is going to go anteriorly. The teres minor is going to go posteriorly. Okay, so the teres minor is posterior to the triceps long head tendon right here. The teres minor is behind it. The teres major is in front of it, and they're going to create this these three spaces. You guys get this concept? Okay, now the contents of these spaces are very important, and you're definitely getting questions about them. The first space created between the teres minor muscle and the teres major and the humerus and the triceps long head tendon is going to be the quadrangular space. That's going to have the axillary nerve and the posterior circumflex humeral artery and vein. You should memorize these contents of these spaces because they're very, very important. Now, the upper triangular space is going to have the circumflex scapular artery. The lower triangular space is going to have the radial nerve and the profunda brachii artery and vein. Now, as we said earlier, for the humerus, there are two types of fractures. There is going to be the fracture at the surgical neck, and which is the most common site, and the fracture down here at the mid shaft fracture. So since it's at the surgical neck, what structures do you expect to get injured? These structures, the ones that are found in the quadrangular space. So if you get any questions that's relating to a surgical neck fracture or a dislocation, for example, in the shoulder, since it's a dislocation in the shoulder, it will be going down, then these are the closest structures to it. So any surgical neck fracture or like type of dislocation on the shoulder or quadrangular space problems, axillary nerve, posterior circumflex humeral artery and vein. Any mid-shaft fracture, it's going to damage these two structures, the radial nerve and the profunda brachii artery and vein. Okay, is this concept clear?
Can you repeat it again?
Which part? Like how they form the position? Okay, I'm going to go over it all again.
Yes,
So there's the humerus right here, and this is the triceps. Okay, let's consider this a scapula. So the triceps is attaching over at this part of the scapula. And down there, we're going to have two more muscles, the teres minor and the teres major. Always associate the teres major with the pectoralis major because they are both major, a major and a major. So since the pectoralis major is anterior, so the teres major is anterior. The teres minor is going to go posterior. It's going to be behind the triceps and attaching over at the posterior side of the humerus. Okay? And we said that teres minor is going to attach at the greater tubercle, right? So would it be easier for it to go all the way from the front to attach at the back? Or would it be just like from the back to attach over at this point? Like that would be much easier. It's like if you didn't remember that, but I think it's easier to know that a major follows a major. So the teres major is anteriorly and teres minor is posteriorly. Now, once these muscles have attached in that way, they're going to create three spaces. This first space, which is the quadrangular space, the second space, which is the lower triangular space, and the upper triangular space. Okay. Now, these three spaces.
Sorry for cutting you off, but I have a small question. The muscles that are included in these like spaces is the triceps, the teres minor and the teres major and the humerus, right?
Yes. Yep. The
So
triceps, the teres minor, and the major and the humerus.
Okay.
You can see it right here. This is the teres minor. This is the teres major, which is like under the teres minor. This is the triceps, and this is the humerus, creating these four spaces, the quadrangular, the upper triangular, and the lower triangular space. But what's more important is knowing the contents, and basically any type of surgical neck fracture at the upper part of the humerus joint or the humerus bone, it is going to damage the quadrangular space contents, the axillary nerve, and the posterior circumflex humeral artery and vein. A surgical neck fracture is going to damage these two things. A mid-shaft fracture is going to damage, since it's at the mid-shaft or at the lower part, it's going to damage the radial nerve and the profunda brachii artery and vein. And there is the circumflex scapular artery that's coming in the upper triangular space. Okay? All good? All right, this is another picture for you guys to see. So a surgical neck fracture over at this region is going to damage the axillary nerve and the posterior circumflex humeral artery, while a mid-shaft fracture is going to be damaging the radial nerve since it's the one that's passing over at the mid-shaft. Now the teres major muscle is going to be attaching over at the medial lip of the intertubercular sulcus, and it's going to be, it's referred to as the baby lats muscle. So let's talk about the functions of the teres major muscle. So a teres major is going to be coming from the back side, attaching over medially. So it's contracting like that. What did it do? It basically did medial rotation, adduction, and since it's from the back, it's going to do extension. All clear? And it's referred as the baby lats muscle. Okay, the next muscle is going to be the deltoid. It's not, I would say, important muscle to know, but there's not much clinical significance around the deltoid. Basically, the deltoid is going to be made of 3 fibers: the anterior fibers, the medial fibers, and the posterior fibers. Now, the anterior fibers, since they're going to be over at this point and they're attaching at the deltoid tuberosity, which is found on the humerus. So what are they going to do once you flex this part? Exactly, it's going to flex the arm and move it forward. It's going to adduct it slightly and medial rotate it slightly. That's why it's a weak adductor and medial rotator, assisting the pectoralis major. The next muscle is going, next fibers are the middle fibers, which are from the middle side, which are going to cause, as you contract it, it's going to create abduction, which is basically moving it further away. And it's the strongest abductor. And again, we mentioned earlier, the muscle that's responsible for initiating or starting the abduction from angle 0 to like angle 15 was which muscle? The muscle that's going under here, the supraspinatus muscle. So the supraspinatus initiates the abduction. The middle fibers of the deltoid take over and complete the abduction. And then we got the posterior fibers, which are going to be responsible for doing the extension, adduction, and lateral rotation. Since it's bringing it backward, it's pulling it back and extending it. Okay. Yes, so that was all for the muscles of the shoulder region. Do you guys have any questions about them? The impingement syndrome. Okay, yes, so the impingement syndrome is basically due to the bony regions. As you can see right here, this is the acromion process, and this is it's going to be connected to the clavicle. Okay, let me go back 1 second. Okay, so the acromion process of the scapula is attaching with the clavicle, and together they're creating basically this small tunnel between the arc that they're creating and the shoulder bone, the humerus bone, I mean. Now, in the contents of this space is going to be the subacromial subdeltoid bursa, which is the same thing. Refer to it as subacromial bursa. It's most likely going to come as the subacromial bursa, but it's good to know that it's under the deltoid, referred to as the subdeltoid bursa, and the supraspinatus muscle tendon. Now, what happens in the impingement syndrome, since these two muscles or these two structures are going to be passing down here, any type of, for example, hypertrophy of the supraspinatus muscle or any inflammation on the supraspinatus muscle is going to create an impingement or impinging the deltoid bursa, the subacromial bursa, and the subdeltoid bursa over at the acromial process. And therefore, when you're trying to basically abduct your arm, you're compressing it more and you're creating this inflammation and you're creating this pain. So impingement syndrome is the same as the painful arc syndrome. Okay. Okay, so the main action that's performed by the deltoid, again, just like the main action, it depends honestly. Like if I was asked that question, then I'd most likely go for abduction since it's like the main abductor of the arm. But it also helps, it only assists in the flexions. The anterior fibers are assisting in flexion, adduction, and medial rotation, while the posterior fibers are assisting with the extension, adduction, and lateral rotation with the latissimus dorsi. The main function would probably most likely be the abducting the arm at the shoulder. If you were asked that question in an OSPE, you can probably mention the anterior fiber, the middle, and the posterior fibers, and like give one function of each, or the function, or the functions of them. The impingement syndrome again. Okay, so the impingement syndrome. There are two bony landmarks: the acromion process and the clavicle, which are creating this tunnel that's going to be passing under them. Now, this tunnel is going to be superiorly covered by the acromion and the clavicle, and inferiorly by the humerus. The contents passing through this tunnel are the supraspinatus muscle, supraspinous muscle tendon, and the subacromial bursa. Whenever you're basically having any hypertrophy of the muscle or inflammation of the muscle or any type of excessive abduction, for example, what's going to happen is that you're going to have the deltoid, the subacromial bursa impinged under the acromion process while you're doing this abduction, and basically it's going to create a lot of pain. Okay. Could you show how the flexion and extension of the deltoid takes place? If you could demonstrate it. Okay, sure. So first of all, the deltoid, the anterior part of the deltoid is going to be coming over at this region. Let me show you guys so you can see the picture. Okay, so it's over. Now this is only showing the posterior part and the medial part. Now the anterior part is going to be coming over here, and it's attaching down here at like the middle part of the deltoid tuberosity and the middle of the humerus. So if a muscle is coming here, and once I flex it, right, I'm flexing it, I'm pulling it back. What happened is that my arm is moving forward. Since it's attached over here, it's pulling it forward. So it's flexing my arm. And since it's over here, it's also going to help. And since it's coming like from this part, it's going to help in adducting it and medially rotating it. But it's a weak adductor and medial rotator. Now the posterior fibers, they are coming from the back. So what they're going to do is that as they attach down here at this part, they're going to extend it or pull it backward as you contract them. And since they're from the back and attached at this part, they're going to laterally rotate it slightly, and they're going to adduct it. Since they're from the middle side coming laterally, they're adducting it and they're extending it. I can't get the difference between it. There's no difference between it and the painful arc syndrome. Yeah, they're the same thing. It's just because of the pain that you're going to have. Or the painful arc syndrome is like basically deferring to the pain because you're creating this arc at this angle after like between the like 15 and 125 angles degree. Like you're going to have this pain because of the inflammation that occurred. And why did this inflammation occur? Because the bursitis for the subacromial bursa got impinged under the acromial process. Yeah, they're the same thing.
Can you please show me slide 31?
Slide 31.
Yes, please.
Yeah. This one?
No.
30, 29, 28, 32.
Yeah, that one.
Like this?
No, the
This?
previous. Yeah, this one. Thank you.
It's found in your lecture.
Yeah, but I want to see the highlighter thing.
Okay. I just pointed out that the acromial process and the humerus, what happens is that they get narrowed to, for example, anything that happens to the supraspinatus muscle, and that's going to cause like compression of the bursa.
Thank you.
Of course. Okay, any other questions? Should I move on to the joints? There is a surgical neck fracture. The axillary nerve gets damaged. So wouldn't the deltoid and teres minor get inactivated? Yes, exactly. That's what's going to happen. Now, okay, yes, of course. Like any damage to the nerves, any damage to the arteries, any damage to the artery or the nerve will cause hypertrophy. Okay, like keep that in mind. Like you might get questions about that. If you get any damage to the nerve or an artery, the muscle won't function and you'll get not hypertrophy. It's like the muscle wasting. Yeah, you're gonna have muscle wasting because you can no longer use this muscle since the nerve supplying the muscle is like damaged. Okay, like that's why you should know what nerve is supplying each muscle. Like that's why you should know all the nerves, because any damage to the nerve, you're gonna have no longer access to that muscle. Atrophy, yeah, atrophy. Sorry, I forgot the word. All right, I'm gonna go over to the joints now. Okay, so the three joints that you should be aware of are gonna be the shoulder joint, which is the main joint, the glenohumeral joint. The other joint is going to be the joint created between the clavicle and the acromial process, so the acromioclavicular joint. And then the last joint, which is going to be created between the clavicle and the sternum, so the sternoclavicular joint. All right, so let's go into the shoulder joint. Now, the type of shoulder joint is basically a ball and socket joint. It is going to be supported by the rotator cuffs. Okay, what I need you guys to see in this picture. So basically, the head of the humerus is the ball, right? And it's going to go fit in the socket, which is the glenoid fossa and the scapula. What you guys can notice is that the shoulder joint or the head of the humerus is much larger than the fossa that's created by the scapula or the glenoid fossa. And that's why the shoulder joint is one of the most commonly dislocated joints. And so it needs a lot of support. So we're going to discuss the structures that are providing support for the shoulder joint. And we're also going to describe like how the body was created in order to adapt to this this formation. Okay, so let's start by basically, now this is naming the bone structures. So 1 is the clavicle, 2 is the acromial process, 3 is going to be the coracoid, 4 is going to be the greater tubercle, lesser tubercle, intertubercular sulcus, the head, and this is the glenoid fossa. And then I added another pictures for you guys can see the subacromial bursa. Okay. Do you guys have any problems with naming structures? Okay. So let's look at the shoulder joint. Now, this is a lateral view. We basically removed the humerus out of the shoulder joint. We removed the humerus outside. We took a lateral view of the scapula at the glenoid cavity so that we can see what's happening around. So first of all, we got the glenoid cavity, right? This is the place, or the glenoid fossa, where the shoulder joint, or the head of the humerus, is going to sit. Now, what happens is, as you can see before that, 1 second. Wait, I don't know why I went back. Okay, so the head of the humerus is much larger, right? So it's not going to fit in. What happened is there's something created that's going to be called the labrum, the glenoid labrum. Now, back then when we took it, honestly, it was a little confusing for us. So I brought for you guys this picture so you can understand. Basically, the glenoid labrum is basically an extension that's going around the fossa. So that's like providing more support, like holding in the head more, all right? This is the glenoid labrum. Now, this is the tear on the glenoid labrum because it could get torn. But like just focus on like how the structure of the glenoid labrum is around the cavity in order to hold the head of the humerus. Now, outside that, you're going to have the fibrous joint capsule, since it's a fibrous joint filled with synovial fluids for lubrications and stuff. And then you're going to have the axillary recess inferiorly. Now, outside this glenoid cavity and the fibrous capsule, there's going to be the 3 muscles or the 4 muscles, the 6 muscles or the rotator cuff muscles, supraspinatus, infraspinatus, teres minor, subscapularis. Just name the 4 muscles together. Whenever you want to think of one muscle, think of the 4 together. So these muscles are referred to as the rotator cuff muscles, and they are responsible for providing the support for the shoulder joint, along with other ligaments that we're going to discuss. And then above the supraspinatus muscle, you're going to have the subacromial bursa, which is going to get inflamed, as we discussed earlier. And then you're going to have the acromial process with the coracoid. And over all these muscles, there's going to be the deltoid. Okay. Now, this is a coracoacromial ligament. We're going to discuss it in a second, but basically it's named based on its attachment. This is the coracoid process. This is the acromial process. So the coracoacromial ligament. Okay. Now, the ligament support for the shoulder joint, there are a few ligaments that you should know. Now, first of all, the 3 main ligaments that are supporting the capsule. Okay, these ligaments are supporting the capsule are superior, middle, and inferior glenohumeral ligaments. Okay, these are going to be basically superior, then the middle, and then the inferior glenohumeral ligaments. You're also going to have the transverse humeral ligament. So it's basically the greater tubercle, the lesser tubercle. Between them is the intertubercular sulcus, which is going to have the tendon of the biceps long head. Now, over that, there's going to be this transverse humeral ligament, okay? Because it's the humerus and it's going transversely, so the transverse humeral ligament. And then between the coracoid and the acromion superiorly, providing support, is going to be the coracoacromial ligament. And now, so the coracoacromial ligament, and one more ligament is the coracohumeral ligament. Basically, the transverse humeral ligament is going to continue superiorly over here, or like an extension out of it is going to come, which is going to create the coracohumeral ligament. You can see it better right here. Okay, so the superior, the middle, the inferior glenohumeral ligaments. Then you got the transverse humeral ligaments, which is going to then give up to the coracohumeral ligament, and then you got the acromioclavicular ligament, which is providing support superiorly. Okay, now, what you should point out or like notice from this picture is that basically the shoulder joint is receiving excessive support from the superior side, right? Do you guys all get basically the basic anatomy of the shoulder joint before I get into like more clinical points? I'm going to talk about the shoulder dislocation, like shoulder injuries. Okay, so basically the basic anatomy I think is good for you guys. So as you can see, like the shoulder is receiving excessive support from the superior side, right? And therefore, whenever we're talking about shoulder dislocations, inferiorly, all we got is the axillary recess. So any shoulder dislocation would most likely go to an inferior position. And since also there is a lot of support on the posterior side, it is going to go to anterior inferior dislocation side, which is going to end up like anteriorly, inferiorly under the coracoid process. Okay, let me go over that part. So the rotator cuff muscles, supraspinatus, infraspinatus, teres minor, and the subscapularis muscle, they're going to explain to you guys in the lab how they sit over at the humerus bone right there. So this is going to be the supraspinatus, infraspinatus, and the teres minor. All of them are attached at the greater tubercle on the lateral side. And then the subscapularis there's going to be a distance, which is indicating that the sulcus. And then the subscapularis is attached over at the lesser tubercle. And Now, the basic movement of the shoulder joint is circumduction. It allows for flexion, extension, adduction, abduction, medial rotation, lateral rotation, because it's basically a ball and socket joint. A ball and socket joint allow for all types of movement. Okay, so let's basically talk now about the clinical points or the dislocations. Now, because of the excessive support that the shoulder joint is receiving from the superior side and the posterior side, most common site of dislocation is going to be anteriorly and inferiorly, right? Which is referred to as the subcoracoid position, subcoracoid dislocation, because it's under the coracoid process. Now, if you look right here, remember what was the first space when we created this triangle? The first space we had was the quadrangular space, which is the closest space to the humerus. So if the humerus is going anteriorly and inferiorly, right? It's going anteriorly and inferiorly. What's going to damage? It's going to damage the structures that are found in the quadrangular space. What are these structures? The axillary nerve and the posterior circumflex humeral artery and vein. Okay? So the shoulder dislocations are going to damage the axillary nerve and these structures. And whenever there is damage to the nerve, we have loss of the muscle function, and there is going to be atrophy of the muscle. Okay? Now what happens is basically there is no longer this bony landmark that you're going to get, because the shoulder joint or the humerus is pushed inward, and it's basically no longer creating this protrusion. All right, so as you see, it's a subcoracoid under the coracoid, and this is the subscapularis muscle, which is going to basically pull it in downward, and that's why it's going to move more anteriorly and inferiorly, and it's going to damage the axillary nerve, which is going to be passing around down here. Now, other tear that might occur to the rotator cuff muscles, mainly the supraspinatus muscle, because it's located over here at the acromion arch. So it's going to get injured and could get a lot of damage. Okay, so these are rotator cuff injuries and mostly focus on the supraspinatus tendon, supraspinatus, tendinitis. Tendinitis is always referring to inflammation. Now, the next thing you could have is a frozen shoulder. A frozen shoulder is basically once the capsule that's around the shoulder is going to get inflamed, or capsulitis, so inflammation of the capsule, is going to create an enlargement of the capsule, which is basically going to hold the shoulder joint in place, and you can no longer move it, which is creating something called the frozen shoulder. This is a summary for the basic movement of the shoulder. Now, this is a description of the fractures. This is a surgical neck fracture. And as we said again, a fracture and the dislocation, so the surgical neck fracture and the dislocation are damaging the structure in the quadrangular space. Now, the other two joints that you should know the first one is going to be the joint connecting between the acromion process and the clavicle, so the acromioclavicular joint. Now, the ligaments supporting the acromioclavicular joint are two ligaments. The main one, or the most important one, is going to be the coracoclavicular ligament, which is basically connecting the coracoid and the clavicle. And the other ligament is the acromioclavicular ligament, but it's not as much supporting it, right? Now, it's connected to the trapezoid and the conoid part, which are basically these two projections on the bone that we described earlier, okay? So these are the two ligaments that are supporting the acromioclavicular joint. Now, what's the significance of the acromioclavicular joint? Basically, whenever you hear the word separated shoulder or a sprung shoulder, you just want to think of acromioclavicular joint damage, and you want to think of damage to one of these two ligaments. A separated shoulder or a sprung shoulder, you're thinking about this joint area and its ligaments. If you listen to a dislocated shoulder is the glenohumeral joint. A separated or sprung shoulder is this region. The other thing is going to be the sternoclavicular joint, which is basically connected between the sternum and the clavicle, and it's supported by three ligaments. The interclavicular ligament, which is basically between the two clavicles, the sternoclavicular ligament between the clavicle and the sternum, and the costoclavicular ligament between the costal bodies. Costals are just ribs, so between the ribs and the sternum and the clavicle. So again, any separated or sprung shoulder is referred to that. A sternoclavicular joint, so basically what is going to happen in the sternoclavicular joint, you're going to have the aortic arch. Now, what's the mediastinum? It's mentioned down here in the lecture. So the mediastinum is basically this region in the thorax that you're going to learn more about in the CVP. It's basically just like referring to the middle region inside your chest cavity, okay? Now, what's going to pass through that is going to be the aortic arch and the three great vessels that are going to be rising out of the aortic arch: the subclavian, the common carotid, and the brachiocephalic. Therefore, any type of injury or posterior dislocation at this joint that is going to cause the clavicle to maybe move backward, it's going to probably compress these vessels, which could lead to a lot of problems, which is basically a sternoclavicular joint damage. Now, again, the sternoclavicular joint. And this is the separated or sprung shoulder, okay? So whenever we listen to a separated or a sprung shoulder, all you want to think about is an acromioclavicular joint damage, and think about the two ligaments, acromioclavicle and the sternoclavicular ligament. All right. Now, how you can figure out whether it's a sprung shoulder or not? Basically, this is a normal X-ray. What's going to happen? You're going to have the acromion process that's going to be more superiorly, and then the clavicle that's going to be attaching over at it. But if there is a damage at this joint, the acromion process is going to be pulled down. The clavicle is going to be coming up. Again, what's the muscle responsible for elevating the clavicle upward? The sternocleidomastoid muscle. Okay, never forget that name, because we had a question in the OSP and almost half the students forgot. Okay, so the acromioclavicular joint is going to be supported by these guys, and I think that's all we have for the lecture. The rest is going to be some questions for you guys. This is summaries that Dr. Ataf has put for you, so remember the names. And this is again some main review for the main injuries: a shoulder dislocation, which is the humerus joint; a glenoid labrum, any type of damage at the glenoid labrum; and then the separated shoulder, which is damage to the acromioclavicular joint. Okay, you guys want to solve these questions now? No, of course, you're welcome. Okay, question number 1.
D, supraspinatus.
Yes, question 1, the answer is D. Because basically he referred to the initiation of abduction, which is done by the supraspinatus muscle. Okay, the next question, okay. Now this is another way that I put this question. So yep, exactly, it's the deltoid. I just put it so you guys can notice, like whenever he's mentioning to abduction specifically, like you mostly want to think of deltoid, and he most likely won't bring any supraspinatus with it. But if he's referring to the initiation of abduction, then it's the supraspinatus muscle. Okay, initiation is the supraspinatus. Okay, the next question, the rotator cuff is composed of all of the following except it's D, the teres major, supraspinatus, infraspinatus, teres minor, and subscapularis. Memorize the 4 together. Okay, now what do you guys think? You got 2 answers, 3. Okay, so yes, the answer is C, the coracoclavicular ligament. I get why you might think it's the acromioclavicular ligament, but like since they mentioned the greatest strength and stability, because like if you look at the Dr. Ataf's lecture, when he mentioned the acromioclavicular joint, he just mentioned the coracoclavicular ligament. However, the acromioclavicular ligament, like it does support it, but the main one is the coracoclavicular ligament. Okay, guys? And then this is another question that I brought for you guys, so you can look at like the same concept. And then this one would be, yep, it's the acromioclavicular ligament. Okay. Now, next question, the surgical neck fracture, which artery may be injured? Posterior circumflex. I brought up the slide again for the spaces. This is the surgical neck damage, and this is the mid-shaft fracture damage. Mid-shaft fracture damage. Yes. C, the answer is radial nerve and deep brachial artery. Indeed. This is before the last question. Okay. Got 1 answer so far. Okay, so the answer is it's E, the coracoacromial ligament. It's right here. So basically, be connecting between the acromial process and the crocoid process, the acromioclavicular coracoacromial ligament, and then underneath it, you're gonna have this tunnel. It's gonna have the supraspinatus muscle and the what's called the subacromial bursa. Okay. The last question. This is the last question. Yep, you guys right. It's the subacromial bursa. Do you guys have any like difficulty solving the questions? Like you get how to do them, right?
The one about the ligaments was kind of confusing.
1 second, let me share again. This one, I have this. I don't know why I have these ones. Wait 1 second. Okay, this one, right?
Yes. Like I feel like the question gave no indication as to which ligament we're talking about.
It described the ligament that's going to be going over this space that's created, right? So the acromion process and the clavicle are going to be attaching over here, and then you're gonna have the acromiocoracoid process. So it's basically going underneath all these guys, okay? So the
Can you show where it described it in the question?
Okay, yeah, sure. So basically, he said it's a rotator cuff. So you think about the four muscles, supraspinatus, infraspinatus, teres minor, and the subscapularis. And most of the time, any rotator cuff injury is the supraspinatus because it's because of the its location. Okay. And so if he's talking about a shoulder ligament, that is going to be the muscle is underlying the shoulder ligament. Wait, what's it indeed? Yes, exactly. So the muscle that's underlying the shoulder ligament, which is basically since a muscle of the rotator cuff, we think of supraspinatus. We think about the ligament that's going to be going over the supraspinatus muscle, which is going to be the acromioclavicular ligament.
Okay, thank you.
Always think like rotator cuff injuries, most of the time are supraspinatus muscle. Unless like he brought up a question like there was damage to rotator cuff muscle, and then like one of the other muscles was part of the choices, then you can choose that one. Like if like the choices were about muscles rather than ligaments. If it was anything else, just think of the supraspinatus.
Okay, thank you.
Of course. Do we get the presentation and WhatsApp number? Okay, sure. I'm gonna send it to like the academic 8 people or like no the academics people, and they can send it to you guys. I mostly copied Dr. Ato's presentation because like I try to help you guys like see what points he brings question from. So whenever you're studying alone, you can like see what you should focus on. No worries, you guys. You have any other questions? You're welcome. Was it all clear, you guys? Do you understand everything about it?
Yes, it's all clear. Thank you so much.
And always like whenever you're thinking about muscles and function, just try to imagine that the same way, like it's pulling it. Inshallah.